Good afternoon. This is Dr. Bonnie Jo from UCSF, speaking on behalf of the Society of Breast Imaging. It's my pleasure to talk to you about mammography screening and controversies. I'd like to acknowledge Dr. Edward Sickles from UCSF and the ACR SBI Breast Cancer Screening Leadership Group. Some of the common questions about mammography screening are, when should an average risk woman begin screening mammography? And what are the facts regarding radiation risk, false positives, and overdiagnosis? My message to you all is that mammography has been shown to reduce breast cancer mortality. Screening annually starting at age 40 saves many more lives compared with biennial screening at age 50. In the next 20 minutes, I will be covering the evidence for screening mammography, focusing on randomized controlled trials and observational studies. I will also cover screening controversies or harms, namely radiation, false positives, and overdiagnosis. And then finally, I will talk a bit about risk-based screening and what are some of the issues with taking this approach. Starting with evidence. This is a summary chart showing evidence from 8 randomized controlled trials covering the ages 40 to 69. The way you read this chart is that a relative risk of 1 means no benefit to the intervention, in this case, screening mammography. Overall, the trials show a relative risk of 0.8. This is less than 1, and therefore we conclude that screening is beneficial. Note that the randomized controlled trials underestimate screening benefit. This is because the trials randomized the invitation to screening versus no invitation. In other words, half the women in the trial receive a letter inviting her to screen, the other half does not receive a letter. Now, obviously, this is not the same as randomization of screening mammography versus no screening mammography. So the RCTs underestimate screening benefit because of contamination. Contamination occurs when a woman does not receive an invitation letter, but she seeks screening on her own. How does this happen? You can imagine if there are 2 women in a household, and one woman gets a letter, but both women attend screening together. If the woman whose life is saved by early detection through screening does not get the letter, she is still counted in the control or unscreened group. The other problem with randomized controlled trials is noncompliance. Noncompliance occurs when a woman receives a screening invitation letter but does not get screened. This can happen easily if a woman forgets to go, she's too busy, throws away the letter. If this patient dies due to a late-stage breast cancer, she is counted in the screening group. In summary, the randomized controlled trials rigorously establish the mortality benefit of screening, but underestimate the magnitude of benefit. Observational studies reflect actual clinical practice and more current practice. They include larger populations, and I think they also more accurately reflect the magnitude of benefit or how much benefit there is of screening mammography. Observational studies have also demonstrated similar magnitude mortality reduction for women in their 40s compared to older women. So it doesn't matter what age decade we look at, the mortality benefit is similar across the ages. For example, this is the Canadian Service Screening Experience covering 7 provinces. The overall experience is that there is a 40% mortality reduction from screening mammography. If you break it down by age ranges, In the Canadian service screening experience, women aged 40 to 49 experienced a 44% mortality reduction. Women ages 50 to 59 had a 40% mortality reduction. So why is there controversy? Well, in the United States, there are 3 different screening strategies to choose from. These strategies place differing emphasis on benefits versus harms. And much of the US media attention focuses on the harms or risks of screening. In 2009, and then again updated in 2016, the United States Preventive Services Task Force issued recommendations on screening that differed from their prior recommendation. You should note that formerly, the 2002 publication of the task force recommended screening every 1 to 2 years at age 40. Currently, the task force recommends starting at age 50 and screening every 2 years between ages 50 to 74. They also cite insufficient evidence for screening after age 74. The American Cancer Society guidelines formally recommend annual screening starting at age 40, but now they recommend a hybrid approach. Starting at age 45, they recommend annual screening 45 to 54, and then screen every 2 years from 55 to 84. Now, they did make a comment in their publication that most women would choose annual screening at 40. The American College of Radiology and the Society of Breast Imaging guidelines have always been the same. Formerly, the ACR and the SBI recommended annual screening starting at age 40. Currently, this is still the recommendation, annual at 40. And the emphasis is on saving the most lives and maximizing life years gained through early detection. Let's move on to some of the controversies or harms. The harms or risks of mammography screening that often come up are radiation, false positives, which incorporate anxiety, inconvenience, and morbidity, and then overdiagnosis. What about radiation? Well, there is general consensus that radiation risk from screening mammography is negligible and pales in comparison to benefits. The radiation from a screening mammogram is quite small. For a bilateral 2-view mammogram, this is equivalent to about 2 months of natural background radiation. I live in the San Francisco Bay Area and am exposed to about 3 millisieverts of natural background radiation per year. A screening mammogram is about 2 months worth of living in the Bay Area. What about false positives? In terms of anxiety, it turns out that 86% of women view recall as an acceptable trade-off for earlier breast cancer diagnosis. On average, a woman will experience a false positive outcome 1 out of every 10 to 12 exams. Also, anxiety usually is eliminated as soon as diagnostic imaging shows no cancer. In other words, the anxiety from having an abnormal screening mammogram is just a temporary state. It's short-lived. And then once a diagnostic study shows that the patient is doing fine, her anxiety is gone. For example, here's a screening exam. On the MLO view, there's an asymmetry. We don't see it on the craniocaudal view. This exam is interpreted as BI-RADS 0 or incomplete with a recommendation for additional imaging evaluation. So the patient has to be recalled for a diagnostic workup. Here's her screening exam for reference. Here's the repeat MLO from her diagnostic exam. Notice that the asymmetry now appears to represent normal breast tissue. And indeed, this is an asymmetry that gets resolved as a superimposition, which is quite common, And the final assessment is BI-RADS1 negative. Asymmetry due to superimposition of normal breast tissue is what we state in the report. Also, this is a great time to point out that screening with tomosynthesis, also known as 3D mammography, reduces false positives from superimposition. Also, screening with tomosynthesis, or DBT, can increase cancer detection. For example, in this case, there was a mass identified only on the digital breast tomosynthesis portion of the exam. You could question a dense area here on the full field digital mammography image to your left. However, the DBT slice to the right shows that there is a mass with architectural distortion. Here, on spot compression magnification view, you can see the arrow pointing to distortion. This was not well seen on a lateral projection, but fortunately, the DBT stack localized this to the lower inner breast. At time of ultrasound, we were able to find a correlative mass, and this indeed turned out to be a cancer. Continuing with some of the harms of mammography screening in terms of false positives, what about false positive biopsy? In the United States, less than 2% of screening exams go on to biopsy. You have to remember that a quarter to a third of these biopsies are true positives, meaning that we do make a cancer diagnosis. In fact, there is 1 year of life gained per benign biopsy, as shown in CISNET models. What about overdiagnosis? Well, overdiagnosis means finding a cancer that will not kill the patient. The patient dies with her disease, not from her disease. The magnitude of overdiagnosis can only be estimated, not measured. And estimates vary widely, and this can be because of lack of adjustment of confounding factors. For example, when there is no adjustment, overdiagnosis rates can be estimated as high as 20% or more. If you do adjust for confounding factors, then the overdiagnosis estimate is well below 10%. Now, regardless of the magnitude of overdiagnosis, what impact does this have in terms of age at first screening? The answer is none. Why do I say that? This is because the overdiagnosed cancer is still found whether you start screening at age 40 or age 50. Starting at age 50 only means you find this overdiagnosed cancer 10 years later. It doesn't kill the patient, and therefore it will still be there to be found on the next screening mammogram. Similarly, what impact does screening interval have on overdiagnosis? Again, I would say the answer is none. The overdiagnosed cancer will be found on the annual screen, or it will be found on the screening exam performed 2 years later. Let's move on to risk-based screening. What about risk-based screening? This is a proposal to get more bang for the buck, as the American saying goes. The problem is by reducing the buck, or the dollar, you also reduce the bang. The problem with risk-based screening in this young 40 to 49 age group is that if you try to limit it based on family history or breast density, you would miss a substantial portion of breast cancers. 80% of cancer patients who are diagnosed between the ages of 40 to 49 have no family history. 75% of cancer patients diagnosed between 40 to 49 had neither very strong family history nor extremely dense breasts in our own UCSF population. That said, how do these screening strategies compare? This is a chart showing the percent mortality reduction of the 3 screening strategies. The first line shows annual 40 to 84. This would be the SBI and ACR recommendations. You can see that from the CISNET models, there is an almost 40% mortality reduction. If you follow the hybrid approach from the American Cancer Society, you get about a 31% mortality reduction. And if you're following the task force approach of biennial 50 to 74, you will only achieve a 23% mortality reduction. In essence, the less intensively you screen, the less benefit you'll have in terms of mortality reduction. However, if you look at the column in terms of number of exams, you will definitely save on number of mammograms. Now, in addition to looking at mortality reduction, it's also important to look at life years gained. If you screen annually at 40, you will gain more life years compared to screening biennially 50 to 74. The number needed to screen per death averted is only 84 when you look at the annual 40 to 84 approach. You actually need to screen more. You need 144 screens to avoid one death in the biennial approach. And interestingly, the number needed to screen to achieve one life year gained is only 5 mammograms. So the National Comprehensive Cancer Network, the ACR, and the SBI all recommend screening for average risk women of annual starting at age 40. And this is to save the most lives and to maximize the number of life years gained. Screening strategies starting at age 50 may disadvantage non-white patients. Race and age distribution of breast cancer in the United States was recently published. This was a study of our U.S. cancer registries and incorporated 747,000 women, 40 to 75, with breast cancer. The age distributions of breast cancer were different for white versus non-white patients. For white patients, they peak in the 60s, whereas the non-white patients actually peaked in their 40s. In fact, 33% of Asian patients with breast cancer are actually diagnosed before age 40 in the United States. So this is a graph showing the peak incidence for whites in the U.S. is in their 60s. If you look over here, the peak incidence for non-whites, that would be the Asian, Hispanic, and Black populations, is actually in the 40s. So remember, without mammography screening, breast cancers are going to present later. These happen to be two different patients. One is a very graphic picture of a very large mass that has eroded through the skin. The other is a CT scan from our county population. Again, a very late stage presentation of breast cancer. Two sad scenarios. The good news now is that 2D mammography has evolved over time. From the early days of direct exposure and film screen mammograms, we now have full field digital mammography. I should point out that all of our historical screening trials were based on analog film. There were no digital mammograms included in those randomized controlled trials. Today, the majority of U.S. practices are full field digital or, even better, tomosynthesis type exams. In fact, DBT has been termed a better mammogram because it reduces false positives and it can find more cancers. So once again, my message to you all is that mammography has been shown to reduce breast cancer mortality. Screening annually starting at age 40 saves many more lives compared with biennial screening at age 50. If you want to learn more, you can go to the Mammography Saves Lives website, which will give you a lot of useful facts and figures regarding mammography screening. Thank you so much for your attention.